Hi guys, so we're starting day 2 and we're going to start it strong with coronary artery disease. So we know that atherosclerosis causes CAD, and we know that CAD is also called or can also be called atherosclerotic heart disease. It can also be called cardiovascular heart disease, ischemic heart disease, and coronary heart disease. These are all the same things and the terms are used interchangeably throughout the medical field. Once the person starts having symptoms, that's when the disease has advanced. Let's talk about collateral circulation, your third bullet point right there. So collateral circulation is when the coronary arteries have other paths for blood to flow down should blockage occur. And two factors influence collateral circulation. First, the inherited predisposition to develop new blood vessels, and two, the presence of chronic ischemia. So when occlusion of the coronary arteries occurs slowly over a long period, there is a greater chance of adequate collateral circulation developing, and the myocardium may still receive adequate amount of blood flow and oxygen. However, if the patient has sudden onset of coronary artery disease, there's no time for collateral circulation to develop, and diminished blood flow results in a more severe ischemia or infarction. We know that the incidence of coronary artery disease is a lot higher among white, middle-aged men, and which is odd, right? Because we learned that hypertension is prevalent in African American women, so it's completely the opposite. After 65, the incidence equals between men and women. African American women have a higher incidence though than white people from acquiring CAD. And of course, if there's a family history of heart disease, then their chance increase 40 to 60%. Some of the modifiable risk factors tend to be proportional to the amount of the risk factor, meaning the more you smoke, the more at risk you are for coronary artery disease. Things like elevated serum lipids is one of the 4 most firmly established risk factors. So a serum cholesterol level above 200 or a fasting triglyceride level of less than 150 is going to put you at risk. And we'll talk more about this on the next slide. Hypertension obviously increases the rate of atherosclerotic development and increases the risk of death from coronary artery disease by a tenfold. Also, you are up to 6 times more likely to have coronary artery disease if they use tobacco. What's interesting though is that within 12 months of smoking cessation, coronary artery disease mortality rates drop to those of non-smokers. So it equalizes between smokers and non-smokers when they quit for 12 months. So teach your patient that it's not too late. We can still get you back down. Exercise increases lipid metabolism and it increases HDL levels. Remember, HDL is the good cholesterol, and helps the body to more efficiently use oxygen, thus decreasing the cardiac workload. Let's talk about obesity. So obesity is defined as a BMI greater than 30, and ideal BMI is 18.5 to 24.9. Also, people with diabetes are 2 to 4 times more likely to have coronary artery disease. They have alterations in lipid metabolism and tend to have high cholesterol. A psychological state, we've once thought to be type A, it puts you at risk for coronary artery disease, but now studies are also looking at people with depression and anxiety and, relationship issues can also put them at risk for coronary artery disease. So basically, if the stress level is too high, anything that, causes extreme change in emotions. High homocysteine. Homocysteine is produced by the breakdown of essential amino acid methionine, and it's found in dietary protein. So what we're trying to say is it seems like a very high protein diet can be damaging to the vessels. And then of course substance abuse like cocaine, methamphetamine can produce coronary spasms that result in myocardial ischemia. More often these clients have sinus tachycardia, high blood pressure, angina, and anxiety due to the substance abuse, but it can lead to MI and stroke in severe cases. So looking at this levels, what do you think? Cholesterol, triglycerides, and LDL are all ideal, right? These are very good readings. However, the HDL could be better if it's higher. So overall, good report. How do you think we could increase our HDL or our good cholesterol? We can teach them not to smoke, right? As is always the case, smoking only makes health problems worse, and that includes HDL levels. Teach them to exercise more, maybe decrease body weight or eat healthier fats. We want to reduce the refined carbs, white bread, sugar, right? Opt for quality healthier carbs like sprouted breads and fruits. Teach them to keep the alcohol consumption moderate or low. And increasing niacin, which is a B vitamin, with niacin-rich foods like turkey, chicken breast, peanuts, mushrooms, liver, tuna, green peas, grass-fed beef, sunflower seeds, and avocado can also help increase HDL. And also, let's review their medications because some steroids, beta blockers, and benzodiazepines, as well as progestins, can actually depress our HDL levels. So remember, metabolic syndrome is a cluster of conditions that occur together that increase your risk of heart disease, stroke, and type 2 diabetes. And with metabolic syndrome, you're going to see obesity, but it's going to be particularly central obesity. We also know that people with metabolic syndrome are at increased risk for developing coronary artery disease. And we know that one of the risk factors for coronary artery disease may be related to insulin resistance that we see. So what is the nurse's goal? What is our role when it comes to health promotion of coronary artery disease? We want to teach, right? We want to teach all about preventing it. We want to try and avoid our patients getting there or at least the disease advancing. Because we know that the appropriate management of risk factors in coronary artery disease may prevent, modify, or slow the progression of the disease. In the United States, there has actually been a gradual decline in cardiovascular disease-related deaths over the past 35 years. And this relates to the efforts of people to become generally healthier, as well as advances in the treatment of coronary artery disease. Prevention and early treatment of heart disease must involve a multifaceted approach and needs to be ongoing throughout the lifespan. So let's talk about identification of high-risk person. We know that the clinical manifestations of coronary artery disease will not be apparent in the early stages of the disease. Therefore, it is extremely important to identify people at risk for CAD. A risk screening is going to be something that involves obtaining a thorough health history. So you want to question the patient about family history of heart disease in parents and siblings. Note the presence of any cardiovascular symptoms. Assess environmental factors such as eating habits, type of diet, and level of exercise to elicit lifestyle patterns. Include a psychosocial history to determine tobacco use, alcohol intake, any recent stressful events like maybe a loss of a spouse or divorce, and the presence of any negative psychological states. Do they suffer from anxiety, depression, anger management issues? The place of work and the type of work provides important information on the kind of activity performed. Are they being exposed to pollutants or toxins? And what is the degree of stress associated with their job? Identify the patient's attitudes and beliefs about health and illness. This information is going to give you insight to how the disease and lifestyle changes may affect the patient. It also can reveal possible misconceptions about heart disease that the patient may have. And then we're going to go ahead and move on to management of high-risk persons. So once we identify who is at high risk, how are we going to manage them? We're going to recommend preventive measures for all persons at risk for coronary artery disease. Risk factors such as age, gender, ethnicity, and genetic inheritance cannot be modified, right? So we're going to work on the modifiable stuff. However, the person with any of these risk factors can still reduce the risk of coronary artery disease by controlling the additive effects of modifiable risk factors. For example, a young man with a family history of heart disease can decrease the risk of coronary artery disease by maintaining an ideal body weight, getting adequate exercise, reducing intake of saturated fats, avoiding tobacco, and illicit drug use. People who have modifiable risk factors should be encouraged to make lifestyle changes to reduce the risk of coronary artery disease. As a nurse, you can play a major role in teaching health-promoting behaviors. For highly motivated persons, knowing how to reduce this risk may be the information that they need to get started. Maybe they just don't know how to get started, but they want to get there, and this is where you step in. For people who are less motivated to take charge of their health, the idea of reducing risk factors may be so remote that they are unable to perceive a threat of coronary artery disease. Few people desire to make lifestyle changes, especially in the absence of symptoms, because they don't feel bad, they think everything is going dandy. So first, help these patients to clarify their personal values, then discuss risk factors and have them identify their individual risk. This can help the patient set realistic goals and choose which risk factors to change first. Some persons are reluctant to change until they begin to have symptoms or actually suffer an MI. Others, having suffered an MI, may find the idea of changing lifelong habits still unacceptable. You must be able to identify their choices and respect them at the end of the day. It is their decision. Another part of health promotion involves physical fitness. A physical activity program should be designed to improve the physical fitness by following the FIT formula. F stands for frequency, which means how often. I, intensity, which means how hard. Type, we want it to be isotonic, and time, for how long. So everyone should aim for at least 30 minutes of moderate physical activity on most days of the week. In addition, adding weight training to an exercise program 2 days a week can help treat metabolic syndrome and improve muscle strength. Examples of moderate physical activity include brisk walking, hiking, biking, and swimming. So it doesn't mean that, you have to go to CrossFit. The simple things like that are sufficient enough to create moderate physical activity. Regular physical activity helps with weight reduction, reduces metabolic blood pressure, and in some men, more than women, it actually increases the HDL cholesterol. Nutritional therapy is everybody's least favorite part, right? But the National Heart, Lung, and Blood Institute recommend therapeutic lifestyle changes for all people to reduce the risk of coronary artery disease by lowering the LDL cholesterol, which is our bad cholesterol. These recommendations are going to emphasize a decrease in saturated fat and cholesterol and an increase in complex carbohydrates such as whole grains, fruit, vegetables, and fiber. Red meat, egg yolks, and whole milk are products of major sources of saturated fat and cholesterol and should be reduced or eliminated from diets. If the serum triglyceride level is elevated, alcohol and simple sugar should be reduced or eliminated. Patients with coronary artery disease are encouraged to take an EPA and a DHA supplement, basically fish oil, with their diet. The AHA also recommends eating tofu and other forms of soybean, canola, walnut, and flaxseed because these products contain alpha-linolenic acid, which becomes omega-3 fatty acid in the body. Lifestyle changes, including a low saturated fat, high fiber diet, avoidance of tobacco, and increase in physical activity can all promote the reversal of coronary artery disease and reduce coronary events. Omega-3s are found naturally in some foods and are added to some fortified foods. You can get adequate amounts of omega-3s by eating a variety of foods including the following: fish and other seafood, especially cold water fatty fish such as salmon, mackerel, tuna, herring, and sardines. Nuts and seeds like flaxseed, chia seeds, and walnuts. Plant oils like flaxseed oil, soybean oil, and canola oil. And fortified foods such as certain brands of eggs, yogurt, juices, milk, soy beverages, and infant formulas can also have omega-3s. Statins. So the way statins work is that they restrict lipoprotein production, which is basically a fancy way of saying that they block the synthesis of cholesterol. The great thing about statins is that they're usually tolerated very well. So who are we going to give statins to? We're going to give statins to patients with a known cardiovascular disease or a healthy patient but that has primary elevations of LDL cholesterol greater than or equal to 190. Maybe in his family high cholesterol runs, but he has no other disease processes. Or those who are between 40 and 75 years old who have diabetes and an LDL cholesterol level between 70 and 189. However, there can be some complications to statin. Something called rhabdomyolysis can happen, and that's when the breakdown of skeletal muscle occurs. And this can also lead to kidney failure. So we want to monitor the liver enzymes and the creatine kinase if the patient is having muscle weakness or pain. Remember, we talked about this. This is the enzyme that shows general breakdown of muscle. CKMB was the one for cardiac muscle, and CKMM is the one for skeletal muscle, which is the one that we're looking at when we're looking for rhabdomyolysis. Okay, some other cholesterol reducing medications that we use or may encourage. Niacin, also known as niaspan or vitamin B3, works by inhibiting the synthesis and the secretion of LDL. LDL is the bad cholesterol, remember? Its main effect is to increase the HDL, the good cholesterol. However, some of the side effects that it can cause skin flushing, and they can actually also take it with aspirin to help lower the skin flushing side effect that comes with it. Gemfibrozil is a fibric acid, and it works by decreasing the hepatic synthesis and secretion of LDL. The main effect of this is to lower the triglycerides. However, it can cause GI disturbances. And if your patient is on Coumadin, remember that it can increase the effect of Coumadin. Why that happens, we have no idea. We just know that if they take Lopin or Gemfibrozil, which is the genetic name, with Coumadin, the effect of Coumadin is exacerbated. Then we have something called cholesterol absorption inhibitors, which basically inhibit the intestinal absorption of cholesterol. An example of this drug is Zetia. It's the one on the right-hand side. And it works by inhibiting the absorption of ingested fats. But because of that, it may cause severe GI disturbances. Angina is just a very fancy word that means chest pain. And we're going to have chest pain when there's a decreased oxygen reaching the cardiac muscle. Whether that be because of increased demand for oxygen, maybe the patient is working out and that oxygen is getting sent to other body parts, or because there's a decreased oxygen reaching the cardiac muscle due to the decreased supply because there's blockage in that artery or vein. We can divide it into two categories: chronic stable angina and unstable angina. There's different types of chronic stable angina, but the main ones that I want you to remember are the ones that are listed on the slide. I will discuss the other two, but just know that they're not as important as the ones that are listed on the slide. And then we also have unstable angina. So let's start with chronic stable. So stable angina is going to be chest pain that occurs intermittently over a long period with the same pattern of onset, duration, and intensity of symptoms. So this is going to be that patient that every time he goes out and mows the yard, his chest starts hurting. But then he comes home, you know, he sits down for a little bit and the chest pain goes away. Or he takes his medication and it goes away. So stable angina improves with rest, and it can be just as little as 5 to 10 minutes of rest helps that pain go away. It can also improve with their nitrates. So this pain is usually going to radiate to the neck and the left shoulder. The problem with stable angina is that there's a category that falls under it that's called silent ischemia, and this is where they have no signs or no symptoms, so no pain whatsoever. This is going to be very common in diabetics. They're going to have the same prognosis, it's just harder to identify, and you know, they go on for a long time without us knowing that there is a problem going on with their heart. Then there's something called Prinzmetal's angina, which is caused by spasm of a major coronary artery. This is going to be common in patients with migraine headaches. It's not related to exercise or increased physical demand. Other types of chronic stable angina is going to be nocturnal angina, which happens exactly how the name states. It's not necessarily while the patient is lying down or sleeping, but it happens at night. So every time, you know, 8 p.m., 9 p.m. rolls around, they start having this chest pain. And then we have something called angina decubitus, which only happens while the patient is lying down. And it's usually relieved when the patient sits up or stands. Okay, so moving on to unstable angina. Unstable angina is going to have persistent pain. It's not going to be related to activity. It's not going to be relieved with medication. The angina represents an emergency in this case. It's usually going to get worse, and it's totally unrelated to exertion. Many people present with this as their first symptom of coronary artery disease. Other symptoms that people tend to miss are fatigue, shortness of breath, indigestion, and anxiety. These are the main categories of drugs that are used for coronary artery disease. And we're going to talk a little bit more, or tell you a little bit more about in the next few slides. Sublingual nitrites usually are effective within 3 minutes, which is why we tell the patients to repeat the dose if after 5 minutes it's not effective. Also, their duration is about 30 to 60 minutes. And we want to teach our patients that they should carry the bottle around in their pocket if they have any cardiovascular issues or a history of cardiovascular surgery as well. However, be careful to not leave the bottle where the children could get them. And interestingly enough, this medication was actually used as a rat poison for a long time. A few things about long-acting nitrates. So they can cause severe orthostatic hypotension. So we teach the patients that they should have an 8-hour nitrate-free period per day. So this is where for 8 hours they don't take any nitrates whatsoever. Also, headaches can occur related to the dilation of the cerebral blood vessels that is caused by the nitrates. And patients can take Tylenol with their nitrate if it causes them a headache every time they take it. However, headaches should decrease over time because the body starts getting used to it, but the medication will still remain effective. So just because those headaches went away doesn't mean the nitrate is not working anymore. Make sure you pay attention to this slide, right? Because this is your job as a nurse. This is what you have to do for a patient that is complaining of acute chest pain. In the United States, 5 to 6 million people live with heart failure, and there's about 670,000 cases added to that number every year. 80% of those heart failure patients are going to be 65 years old, which makes heart failure the most common reason for hospital admission in patients that are over the age of 65. Okay, so heart failure, what is it? Heart failure is the inability of the heart to pump well enough to meet the demands of the body. I'm sure you've also heard of the term congestive heart failure. The term congestive basically just refers to the fluid that's backing up due to the poor pump function of your heart, or of the heart. So, heart failure is a myocardial muscle dysfunction, and it's also the final pathway for all forms of heart disease. So what that means is that this is going to be where all heart diseases end at. This is the final point of them. What causes heart failure? It can be basically, to sum it up, it's caused by any interference with normal mechanisms regulating the cardiac output. So if there's an interference with the preload, the afterload, if there's interference with the myocardial contractility and the heart rate, any variations in these things can lead to heart failure. And actually, many diseases do this. So we can have primary risk factors or diseases like coronary artery disease, hypertension, advancing age. These are the primary risk factors. But we also have other diseases that can precipitate the causes of heart failure that we don't really think about, like, for example, anemia, obstructive sleep apnea, also hypothyroidism, dysrhythmias, things like that can eventually lead to heart failure if not taken care of appropriately. Guys, get your pens and papers ready and pay attention to this slide because there's a lot of information that's about to be thrown your way. Okay, so we're going to start with the left-sided heart failure. When the left side fails, the fluid backs up into the lungs, okay, which is going to result in what kind of symptoms? Pulmonary symptoms, right? So again, left ventricle dysfunction causes blood to back up into the left atrium and the pulmonary veins, which results in pulmonary congestion. One more time. The pulmonary congestion that you see with left-sided heart failure is due to the inability of the left ventricle to pump blood to the periphery, the rest of the body. Thus, it stays in the lungs, causing congestion. Okay? And then you can also have, under left-sided heart failure, two types of failures. You can have systolic failure or diastolic failure. So let's start with systolic failure. Systolic failure is the inability of the heart to pump blood effectively. Remember, systolic is when we're pumping, right? So that should lead you to be able to remember that if we have systolic failure, it is a pump problem, okay? And the hallmark sign of systolic failure is that there is decreased ejection fraction. The normal ejection fraction is 55 to 60%, but patients with systolic failure, their ejection fraction is going to be less than 45%. So one more time, systolic failure is the inability of the heart to contract well enough to provide enough blood forward, therefore it backs up into the lungs. Then we can also have something called diastolic failure. Diastolic failure is a type of heart failure where we have preserved ejection fraction. So this is, remember what happens during diastole, the ventricles fill, right? So this is the inability of ventricles to relax and fill during diastole. So the left ventricle is going to be still and non-compliant. The end result is going to be the same as systolic. We're also going to have pulmonary symptoms. So to review real quick, left-sided heart failure, left side fails, fluid backs up into the lungs. This can be broken down into further two sections. We can have systolic failure or diastolic failure. If it's a systolic failure, it's a pumping problem. The pump is not working correctly. If it's a diastolic failure, it's the inability of the ventricles to relax and fill during diastole. Both of these are going to lead to pulmonary issues, right? Because the fluid is backing up into the lungs. Okay, that was left-sided heart failure. Now let's move on to right-sided heart failure. Right-sided heart failure is when the right ventricle fails to pump effectively. This backs up fluid to the venous system, also meaning the rest of the body, and thus causes movement of the fluid into the tissues and organs. Inefficient pumping of the right side of the heart, causing fluid buildup in the abdomen, including the liver, legs, and feet, results in peripheral congestion. Again, right-sided heart failure leads to peripheral congestion that is related to the inability of the right ventricle to pump blood to the lungs. So in left-sided heart failure, we cannot, the fluid backs up into the lungs. In right-sided heart failure, the fluid backs up into the body and organs, okay? What's interesting is that the most common cause of right-sided heart failure is left-sided heart failure, which causes increased pressure in the lungs, and then the right side has to work harder, and thus over time weakens and fails. Of course, there are other causes of right-sided heart failure, such as infarction, pulmonary emboli, and things like that. But because it is a circular system, when the left side fails, the right side will eventually fail as a result of continued backing up. This is how your typical patient with left-sided heart failure is going to present. They're going to have fatigue. This is going to be the earliest symptom, guys. It's going to be noticed after usual activities that they used to be able to do with no problems are now becoming limited. And this is because of decreased cardiac output is impairing the perfusion to vital organs, and they're getting decreased oxygen in the tissues. They may even have anemia. Then they're also going to have dyspnea, which is a common sign of heart failure, and it happens because of poor gas exchange. Orthopnea is shortness of breath when the patient is lying down, so the patient has to sit up to be able to breathe. Paroxysmal nocturnal dyspnea occurs when the patient is asleep, and it's caused by reabsorption of fluid from the dependent body areas when the patient is lying down. This is going to cause the patient to awaken panicked and feeling like they can't breathe and they're suffocating, and they need to sit up to be able to breathe. So if you know that they have this, you're going to teach your patient that they need to sleep with 2 pillows, their head elevated, okay? And another early sign is going to be dry hacking cough. So fatigue, dry hacking cough, early signs. This is because there's not enough fluid for production and not enough oomph to get it out. They might have, left-sided heart failure patients might have pink frothy sputum, which is a cough that becomes moist over time, and it usually indicates severe pulmonary congestion that is being caused because of pulmonary edema. Tachycardia is also another early sign of heart failure. This is because the heart is trying to compensate. Nocturia, all right, this is due to the fluid movement from the interstitial spaces back to the circulation when they're lying down. This causes increased renal flow and therefore diuresis, and the patient gets up 1,000 times at night to go pee. Skin-wise, you're going to notice that they're going to have cyanosis. They have very poor capillary oxygenation, right? So this is going to lead to dusky appearance, cyanosis. Or they may have cool and damp skin from diaphoresis. Their lower extremities with left-sided heart failure are often going to be shiny and swollen with very diminished or absent hair growth. Chronic swelling of the legs may result in pigment changes, usually a brown or brawny appearance that covers the ankles and the lower legs. And actually, these patients are also going to experience behavioral changes because they're lacking oxygen in their brain. So they're going to be restless, confused. Their decreased attention span or memory is going to be not as good as it used to be. They may also have possible angina as well due to less coronary artery perfusion. What position is this guy sitting in? This is a tripod position, right? How do you think this guy needs to sleep? With 2 pillows, right? Elevated. He might even sleep in a recliner. And what do you think happens when he lays down at night? He probably wakes up, right? Feeling like he can't breathe because now we're having that fluid that's getting reabsorbed at night and he's feeling that congestion. Let's talk about how your right-sided heart failure patient is going to present to you. So remember, when the right ventricle fails, congestion in the peripheral tissues and the viscera is going to predominate. This happens because the right side of the heart cannot eject blood and cannot accommodate all the blood that normally returns to it from the venous circulation. So when we have increased venous pressure, we're going to see something called JVD. This is going to be that jugular vein distension that you're going to see around the neck area. It's going to be swollen. You're going to be able to see it pulsating like you can on that picture. Okay, this happens because there's elevated right atrial pressure from right-sided heart failure. But the main thing you're going to see with right-sided heart failure is going to be edema. In this edema, the swelling is going to be found in dependent areas, so your peripheral areas. This is where you're going to see the indentations in the skin that remain after slight compression with fingertips. So you use your fingertips to press on the patient's legs or foot, and you're going to see an indentation that's going to stay there for several seconds. So this is going to happen if they're retaining at least 10 pounds of fluid, okay, 4.5 liters. If they're retaining that much fluid, this is when you're going to start to see that pitting edema. If they are patients that are maybe constantly lying down, then you're going to see the edema in the sacral or scrotal area. So if they're retaining 10 pounds of fluid, of course they're going to have weight gain, right? That's going to be another thing you're going to see with these patients. The weight gain in 3 pounds, if they gain weight of 3 pounds in 2 or less days, then they are at that moment having an exacerbation of heart failure. Also, the liver, you're going to see something called hepatomegaly, which is where the liver is enlarged. You're going to see tenderness. These patients are going to have tenderness on the right upper quadrant. And this is going to result from the venous engorgement of the liver. And it may also affect the liver's ability to function. And when hepatic dysfunction progresses, increased pressure in the portal vessels may force fluid into the abdominal cavity, causing something called ascites. Ascites is just a fancy word that means fluid in abdominal cavity. As that puts pressure on the stomach and intestines, it's going to cause the patient to have GI distress, which is going to lead to anorexia or loss of appetite and nausea or abdominal pain. Again, these GI symptoms are going to result from the venous engorgement and the venous stasis within the abdominal organs. And of course, these patients are going to present with weakness. Weakness that accompanies right-sided failure results from decreased cardiac output, that in turn leads to impaired circulation and inadequate removal of catabolic waste products from the tissues. Again, main things you're going to see on a patient who has right-sided heart failure. You're going to see edema, JVD, weight gain, hepatomegaly, which is going to lead to GI issues, which is going to lead to anorexia, nausea, abdominal pain, and these patients are going to have weakness as well. The stability of heart failure is going to come and go. We may have times where the heart failure is very well controlled and other times where the patients have exacerbations of it. Regardless of the etiology, acute decompensated heart failure is going to manifest as pulmonary edema. Now, don't get me wrong, pulmonary edema can also have other causes, like for example, if the patient had an MI or has valvular incompetency, these can lead to pulmonary edema. But acute decompensated heart failure is always going to manifest as pulmonary edema. And this is when the heart failure exacerbates. And this usually does happen with heart failure patients. It's going to exacerbate because the left ventricular failure worsens, and it typically worsens secondary to coronary artery disease. Okay, so pulmonary edema, in this case, is an acute life-threatening situation in which the lung alveoli become filled with serous sanguineous, which means blood and serous fluid. So the alveoli become filled with serous sanguineous fluid. This happens because the fluid backs up from the left-sided heart failure into the lungs. The fluids cannot get out of the lungs because there's not enough oomph to push the fluid out. So again, if you have a pen and paper on you, write this down. The patho is, first you're going to have increased left atrial pressure. That's going to lead to increased pulmonary venous pressure, which is going to lead to increased hydrostatic pressure in the pulmonary capillaries that are going to cause the fluid to ooze out of the pulmonary capillaries, and this fluid is going to leak into the alveoli. Now, don't stress too much out about this, okay? I'm not going to make you draw me a diagram of the patho on your exam. I just want you to be able to know why we have this pulmonary edema, why we have this fluid in the alveoli, and it's because the left ventricle is failing and the fluid is backing up into the lungs, and now it's leaking into the alveoli, and we don't have enough pressure, oomph, to be able to push this fluid out. So how is acute decompensated heart failure going to manifest? The manifestations of this pulmonary edema is going to be the same as left-sided heart failure, with one exception, guys. In left-sided heart failure, we have a dry cough. In pulmonary edema, secondary to acute decompensated heart failure, our cough is going to be productive. Okay, you're going to see a bloody sputum with this type of cough. That's because edema is in the lungs, it's in the alveoli, it can't get out, so we see bloody sputum. These patients are going to present as anxious, as restless, because they can't breathe, right? We would be the same way if we couldn't breathe. They're going to have pale skin or cyanotic, because the blood is moving to vital organs. It's trying to perfuse those vital organs first instead of, your fingernails. That's the last thing we care about. That's the last thing the body cares about trying to keep alive is those fingernails. We're going to reserve that blood with oxygen for the vital organs. They're going to have clammy, cold skin from vasoconstriction that's going to be caused by the stimulation of the SNS, the sympathetic nervous system, right? We're going to have dyspnea, labored respirations, abnormal respirations. They're going to be characterized by evidence of increased use of accessory muscles. And you're going to be able to see this in their chest wall. If you take off their shirts, you're going to see those accessory muscles being used when they're breathing. You're going to hear stridor as well, perhaps grunting, and you're going to see nasal flaring. And these patients are very often going to be tachypnic, which means they're breathing higher than 30. They're going to have orthopnea, again, for the same things. crackles, wheezing, coughing, all of this because their lungs are wet. It's filled with fluid. Pink frothy sputum due to the fluid, the red blood cells and the plasma protein that is in the alveoli. They're going to have tachycardia because they're trying to compensate. And their blood pressure can either be increased or decreased depending on the severity. At first, it's going to be increased, right? But when that body is not able to keep up the compensation for that long amount of time, it's going to start to decrease. We're going to start losing the ability of the heart to be able to compensate, and that blood pressure is going to start going down. In the simulation, what kind of symptoms did the nurse observe? What did the nurse practitioner also observe? Patient was complaining of, I can't catch my breath, right? But the nurse notices that the patient is sweaty, hears the patient coughing, and goes to go get the healthcare provider. What else should the nurse probably have done prior to? She probably should have listened to the heart and the lungs and get a full set of vital signs. Then the healthcare provider comes in and she begins the assessment, and she finds out that the problem began about 15 minutes ago. She notices the color of the patient is dusky, that the patient is sweaty, and that she can't breathe. She noticed that there's pink frothy stuff when the patient coughs. She listens to the heart and the lungs and notices a heart murmur. And that's when the patient says, well, I've been told that I have bad valves, right? Which could be a result, or it could be the cause of this heart failure. But also remember from our previous page that causes of ADHF do include valvular insufficiency. So she orders a chest x-ray. Why? Because we want to check for fluid in the lungs. Then she orders BiPAP. What does the BiPAP do? The BiPAP is going to get the oxygen into those lungs. It's also going to decrease the preload. Then she's going to give diuretics. Lasix is going to be the main one. Because why? We want to get that extra fluid out of that patient's body. And we're going to give her morphine to help with whatever pain she may be having in her chest, or to also help relax the patient. A common cardiac drug that we may give is nitroglycerin. This is going to cause dilation of the arteries and the veins, which is going to allow the blood to flow through a lot more easily. Then you might also see dobutamine or dopamine. Anything that is a positive inotrope is going to strengthen the contraction of the heart. So it's going to allow that pump to beat harder. Okay, so in 1964, the New York Heart Association created this kind of classification system that basically stages the heart failure. It goes all the way from class 1 to class 4, with class 1 being a very mild to no limitation. This is called a functional guidelines, and the reason why is because it's based on the person's tolerance level to physical activity. Then later on, the American Heart Association went ahead and developed a new classification system that identifies disease progression as well as treatment strategies and things like that. Their system goes from stage A to stage D. And you're going to see that they're pretty similar. So basically a stage A would be a class 1 under the New York Health Association classification. So why are the classifications important? The reason why is because if a client is diagnosed with a stage 3 or stage 4 and you're looking at their chart before you're even seeing the patient, you should be able to know and identify that they're going to have significant symptoms and their ability to perform self-care is very limited. So again, let's say I'm looking at a chart. Okay, I haven't met my patient yet. I'm just looking at the chart and I'm seeing that this patient has been classified as a stage 4 under the New York Health Association or under stage D under the American Heart Association. Okay? So immediately my mind should go to the fact that this patient is going to be severely limited, probably would need help just to get up and go to the bathroom if that's even something they can do. Okay, versus if they're diagnosed as a class 1 or a stage A, they're probably not having as many symptoms or limitations. It basically helps paint a picture to me on how stable or unstable the patient's heart failure is. All of these are complications secondary to heart failure that can occur. Pleural effusion is when an abnormal accumulation of fluid in the intrapleural spaces of the lungs happens. The fluid is a transudate from the inflamed pleural surfaces, and this typically is going to occur in the right lower lobe first from the increased hydrostatic pressure. Then we can have dysrhythmias because an enlarged heart is going to alter the normal electrical pathway, especially in the atria. The most common dysrhythmia that you're going to see from heart failure is going to be atrial fibrillation. This is often going to be a chronic dysrhythmia that they're just going to have as long as they have this heart failure. And it's well tolerated if it's managed correctly. However, they can have an acute exacerbation of AFib, which will require forward cardioversion. If it's chronic AFib, then we're going to give them anticoagulants so they don't throw out any clots and we don't get a stroke. And we're going to give them antiarrhythmics medications. Then we can also have ventricular tachycardia and fibrillation. The problem with these two is that they can often lead to sudden cardiac death. Atrial fibrillation is a lot more easy to live with. Left ventricular thrombus can happen from an enlarged left ventricle and decreased cardiac output that is going to combine to increase the chances of thrombus formation. So these patients are going to require an anticoagulant. Hepatomegaly, we already discussed this some. It's usually with right-sided heart failure. This is where the liver lobules are congested with venous blood. And the congestion is going to lead to impaired liver function. Apparently I can't say liver today. Which is going to result in fibrosis, which can lead to cirrhosis. And last but not least, a big complication of heart failure is renal failure. Because of the decreased cardiac output that accompanies heart failure, it's going to result in decreased perfusion to the kidneys. And it's going to lead to renal insufficiency or failure. So part of our jobs as nurses, right, is to always get a very good H&P done on our patients, okay? We want to make sure that the signs and symptoms that we're seeing are not something from another disease process, another medical condition that's mimicking this, okay? We also want to determine the underlying cause. Why is this disease being exacerbated? What is going on here, okay? So we're going to ask a lot of thorough questions to our patients, everything from dietary habits to exploring the patient's chronic health problems, because remember how we mentioned in the last lecture that simple things like sleep apnea can be one of the reasons why the heart failure is exacerbated. So maybe our patient has sleep apnea and maybe they don't use a continuous positive airway pressure device at night like they should because they're bulky, they're expensive, and they're not comfortable to sleep in, right? So maybe the fact that they're not using the machine that they should be using, it's what's worsening the pulmonary or systemic hypertension, and this is what's leading to the exacerbation of the heart failure. However, if we don't ask the right questions or enough questions, we will never be able to determine this. So very, very important that you take time to ask thorough questions, okay? So BNP. BNP, remember, this is the hormone that's produced by the heart muscle, and it's released when the left ventricle is stretched or stressed out too much, okay? And remember, fluid volume overload is the thing that's going to stretch our left ventricle. So when we have too much stretching, this is going to increase the secretion of this hormone. BNP, anything less than 100 is normal. Anything higher than 100 is pretty diagnostic for heart failure. The higher the number, the worse the heart failure. All right, so BNP helps us determine the severity of the heart failure. Ejection fraction. This is going to be obtained by an echo. And the ejection fraction, we're pretty much going to be looking at the left ventricular ejection fraction. And this is how much blood is being pumped out by the left ventricle of the heart. The left ventricle of the heart is sometimes known as the workhorse of the heart because it just does the majority of the work. All right, so with left-sided systolic failure, we're going to see that the ejection fraction is decreased. Our normal ejection fraction is about 55 to 60%, okay? The number may vary a little bit depending on the textbook or hospital, but Anything asystolic with an ejection fraction less than 45% is pretty much a sign that we are now encountering left-sided systolic heart failure. We can also have left-sided diastolic failure. Remember, with this type of thing, our echo is in this case going to show a preserved ejection fraction, okay? Because very often these patients have a normal ejection fraction. Digoxin is one of those drugs that you're going to see prescribed often to patients with heart failure. And that's because it treats rhythm problems. So AFib, A-flutter, supraventricular tachycardia, these rhythms that often accompany heart failure, they're going to be treated by using digoxin. What's interesting about digoxin, though, is that toxic amounts can also cause more rhythm problems of the heart. So dosing is very important because it has a very narrow therapeutic range. Digoxin has a positive inotropic action, which means it increases the force of the contraction. So it makes that pump harder. Now, just because it pumps harder doesn't mean it pumps faster, because digoxin also has a negative chronotropic action, which means it slows the heart rate down. So it slows the heart rate down, but makes each of those pumps more effective by making it harder. We want to get a baseline cardiac function labs before we administer digoxin, because we also want to check their electrolytes as well. Because several electrolyte imbalances can cause toxicity, and the most common is going to be hypokalemia, low potassium. I don't know if you remember what we talked about that during our fluid and electrolyte lecture, how hypokalemia increases the chances of digoxin toxicity. Also, hypercalcemia, which increased calcium, increases the effects of digoxin, which means it increases the force of the myocardial contraction. So we have to be careful with that as well. Hypomagnesemia. So magnesium has an inverse relationship with digoxin. So when the magnesium is depleted, which is hypomagnesemia, it increases also the risk for dig toxicity. Those flowers that you see on the slide right there, they're called foxglove flowers. And this is where the digitalis or digoxin preps come from. So it's derived from a flower. So remember, digoxin has a narrow therapeutic window, and that therapeutic window is between 0.8 and 2 nanograms per deciliter. Things that affect digoxin level that can make it high or low include calcium channel blockers, aminoglycosides, anticholinergics, also diabetes and electrolyte imbalances. All these things can affect the digoxin level, whether it makes it higher or makes it lower. Some of the causes of digoxin toxicity can be accidental overdose, kidney and liver disease, and electrolyte imbalances, especially which one? Hypokalemia, low potassium. Okay? So remember this saying, banana a day keeps the digoxin okay. Also, we can also have hypokalemia in these patients because remember, we also tend to give them diuretics, and diuretics cause that potassium to go down. So this is why they may be having hypokalemia. So we want to monitor the levels of their electrolytes and kidney and liver function test as well. Something interesting to teach your patients is that high fiber foods binds with digitalis preparations and decreases the effectiveness. Also, antacids and laxatives decrease the absorption of digoxin. If you have a patient that comes in with an exacerbation of congestive heart failure, you want to remember this mnemonic. You want to unload fast. So you want to put them in an upright position, give them a nitrate to help open up those arteries, veins. Give them a Lasix to unload the extra fluid that they have. Give them oxygen to reoxygenate their peripheral extremities and those organs that are being depleted. Give them ACE inhibitors, digoxin to help that pump be more effective and the heart rate to slow down. If they're on fluids, you want to take those fluids away. That's the last thing they need right now. You want to decrease their afterload. You want to put them on sodium restrictions, right? And you want to test their digoxin level. We want to make sure that they're not having digoxin toxicity. We want to check ABGs. The ABGs is going to tell you how well that arterial blood is oxygenating, and the potassium level, because again, if you have someone on DIG, you always want to check their potassium level. The ultimate goal of the patient teaching is going to be to empower your patients to manage their heart failure by doing some of the things that are listed on this slide, right? So we're going to give them nutritional information, things like limit the salt, show them the difference between a can that's low sodium versus one that's not. Tell them how to use lemon and different spices to substitute the use of salt. You're going to teach them about weighing themselves daily, same time, same clothes, teach them what they need to watch out for weight-wise. Exercise, maybe they want to consider a cardiac rehabilitation program. We also want to tell them to avoid extremes of heat or cold, right? We want them to increase their walking and other activities gradually so that they don't cause fatigue or severe dyspnea. And basically, they have the power. So we want to make them feel like they have them. We want to empower the patients, because if they feel empowered with their care, they're most likely to comply with it. So remember, an ejection fraction that is below normal, it can be a sign of heart failure. If it's below 45, then it's definitely going to be considered systolic heart failure. Remember, left ventricular ejection fraction is the measurement of how much blood is being pumped out of the left ventricle of the heart with each contraction. Moving on to our little bitty babies. So, congenital heart defects. There's a different array of them, but we're going to focus on tetralogy of Fallot in this lecture. The incidence is going to be 5 to 8 per every 1,000 live births, and 2 or 3 of these infants are going to start having symptoms right away in their first year of life. Congenital heart defects is going to be the major cause of death in the first year of life after prematurity. And it's going to be the most common anomaly in ventricular septal defect. In 28% of kids with congenital heart defects, there's going to be another recognized anomaly that's also present. So what are the causes of this? It can be a chromosomal or genetic cause in about 10 to 12% of patients, or maternal or environmental cause in 1 to 2% of these patients. If the mom uses drugs, or if she drinks, the baby can be born with fetal alcohol syndrome, which is actually 50% of the kids that are born with CHD. That is the reasoning, because they have fetal alcohol syndrome from the mother drinking when she was pregnant. There can also be other things like maternal illness, the rubella infection. In the first 7 weeks of pregnancy, it's associated with the 50% risk of defects, including the patent ductus arteriosus and pulmonary branch stenosis. Viral illnesses like cytomegalovirus, toxoplasmosis, which are extremely difficult to pronounce, by the way, can lead to cardiac defects. Also, infants of diabetic mothers have a 10% risk of congenital heart defects, such as ventricular septal defect, cardiomyopathy, and transposition of great arteries are the most common. However, it can be multifactorial in about 85% of the cases, which means there was more than one thing that could have caused that congenital heart defect. You already got this information in your A&P class, so we're going to go over this fairly quickly. Before birth, 2 things happen. The umbilical vein delivers oxygen and nutrients to the fetus, and the blood supply does not go to the lungs. Once that neonate takes their first breath, the gas exchange transfers from the placenta to the lungs. And the fetal shunts, which are the ductus venosus, ductus arteriosus, and foramen ovale, they're going to close. And they're going to close in response to the pressure changes in the systemic and pulmonary circulations. And they're going to close and also because of the increased blood oxygen content. Also, when these close, the pulmonary vascular resistance is going to begin to decrease and the pulmonary blood flow markedly increases. And it markedly increases because remember how I just said they have no blood supply that goes to the lungs when they are in the womb. The closure of the ductus arteriosus along with the increased pulmonary blood flow enhances the left ventricular filling. The increase in the systemic arterial pressure as a result of clamping the umbilical cord at delivery and the placental separation from the fetus increases the workload of the left ventricle, and the neonatal heart functions on its own after that. However, in some neonates, it can take several days for the fetus shunts to close. If your memory is a little muddy in regards to the pathway of circulation that happens in the fetus versus in our normal heart, then I encourage you to go ahead and take a look at those two videos. And the thing is, you're not really going to understand what the problem is of the defects unless you know how the heart normally functions both in the fetus heart as well as in the adult or newborn heart. One of the main things that you're really going to notice with these babies who have cardiac dysfunction is that they're going to suffer from failure to thrive. They're going to have very poor weight gain, and they're going to have a lot of symptoms that manifest, which we're going to cover in the next slide. Okay, so let's talk about TET spells a little bit and what it is. So TET spell is a hypercyanotic event. The exact cause is unknown, but it's thought that a child has acute spasm of right ventricular outflow tract as a result of agitation or another adverse event that dramatically decreases the pulmonary blood flow. So something upsets the child, it causes the right ventricular outflow tract to spasm, and then from there on, we see the causing hypoxia and metabolic acidosis that develops. The episodes include rapid and deep respirations, irritability, and crying. You're going to see some peripheral vasodilation, okay, and increased systemic venous return, as well as increasing cyanosis that can be very severe. And you're actually going to be able to see it in these cases. At least I've been able to see it when I see a TET spell. Their lips really do turn very deep blue. As the child becomes more cyanotic, the child's going to have an increase in tachypnea and hyperpnea, which increases the degree of the right to left shunting that they already have. So, treatment, what are we going to do for these patients? For the babies, well, for the kids, as they're going through this TET spell. First of all, our main goal is going to be to try and calm the infant. Then we want to place them in a knee to chest squatting position. Then we're going to go ahead and administer oxygen. Morphine can be given as well to help suppress the respiratory rate and decrease the degree of the hyperpnea that they're experiencing. And in severe cases, we might have to give a vasoconstrictor. All right, so that we can increase the systemic vascular resistance and decrease the degree of the right to left shunting. Difficulty feeding is going to be the most frequent complaint that you're going to hear with these types of patients. So unfortunately, the babies don't have a lot of energy, right? And they use up all that energy when they're trying to eat. The sucking motion of them drinking milk is enough to exhaust them. So a couple things happen. First of all, they are extremely tired and most of the time do not finish their feeding. And because they don't finish their feeding and they fall asleep during their feeding, they don't get enough milk in their stomachs to be able to hold them off, you know, the 3 to 4 hours or the length that a typically newborn would eat. So sometimes these patients, these babies are babies that are waking up every hour to feed and they feed 5 minutes and then they fall asleep on the mother, okay? In severe cases, when the child is just extremely tired, they actually have to be wakened up to feed. And again, they won't feed too long, they run out of energy, they become exhausted, and then they fall asleep in the middle of the feed. This video is going to go a little bit more in depth as to the whole pathophysiology of the tetralogy of Fallot, or Fallot, however you pronounce it. It's hard for me to pronounce, guys. And how it's composed. This disease is composed of 4 defects that together are called the tetralogy of Fallot. The first defect is going to be the pulmonary stenosis, which is going to impede the blood getting to the lungs. Second one is going to be the right ventricular hypertrophy. That's due to the pulmonary stenosis. The right ventricle is having to work hard to eject the blood because of the pulmonary stenosis, and therefore the muscles become enlarged in the right ventricle. The big one is going to be the ventricular septal defect, which is where the blood is being forced by the right to the left ventricle and is leading to defect number 4, which is the overriding aorta, which receives blood from the right unoxygenated and the left oxygenated blood mixed. So instead of just getting oxygenated blood, it's getting a mix of unoxygenated and oxygenated blood. So the symptoms are going to depend on the degree of the right ventricle outflow obstruction. And severe obstruction and inadequate pulmonary flow is present in immediate newborn period with profound cyanosis. With moderate obstruction, there's a balanced pulmonary flow present with the evaluation of a murmur. And minimal obstruction is going to have increased pulmonary flow that's going to lead to heart failure eventually. And these patients are going to be at risk for an emboli because their hematocrit is going to be elevated 50 to 60%. Remember how we talked about that's one of the things that you're going to see is an elevated RBC and hematocrit level because the body is trying to compensate for the decreased oxygen. As an attempt to maintain the inductus arteriosus, we're going to give PGE1, which is a prostaglandin. And that's going to maintain the patent ductus arteriosus and the blood flow to the lungs. From a surgical standpoint, a complete repair is going to be preferred, and it's going to involve the closure of the VSD. It's also going to require resection of stenosis and pericardial patch. Basically, it's a cardiopulmonary bypass. It's an open heart surgery. It is a very big deal. It has very big risk. If the child is a poor candidate for early repair, then we're going to do something called Blalock Towsing, a BT shunt or a modified BT, which provides blood flow from the right and the left subclavian arteries to the pulmonary arteries. The good thing is that 85% of children with tetralogy of Fallot survive to adulthood. Nursing care wise, what is your job as a nurse when you have a patient like this? Obviously, you want to check their vital signs. You're going to assess respirations, of course. You're going to assess anything that has to do with the heart, right? You're going to listen to the heart. We're going to assess the cardiac output by looking at the color, perfusion, pulses, capillary refill, renal function, and neural status. You're going to listen to the heart sounds, rhythm, see if there's a murmur. Neuro-wise, you're going to check their level of consciousness. We want to make sure there is no air in the IV lines with these type of patients because there's not going to be anything there to stop that air from being able to reach their heart or their brain. So this is one that you absolutely 110% have to flush that IV line until you see no air bubbles, and something that you want to check for every single time. You're going to do their INOs. You're going to take daily weights. After they get the shunts, you want to assess for murmurs, you're going to check their platelet count, and you're going to check for cyanosis. These are the things that you're going to want to focus on as a nurse. You want to promote adequate oxygen, so you're going to administer oxygen per your doctor order, right, or PRN. You're going to put them in loose-fitting clothing because you want to avoid any and all pressure on their abdominal organs. Position-wise, you're going to put their neck slightly hyperextended to keep their airway patent. And you're going to place them in the knee to chest position, so a squatting position for these type of patients. This position is going to help relieve the TET spell. You're also going to suction as needed, right? Because any type of respiratory distress is going to be extremely deteriorating for them. And if they may be placed on digoxin to slow and strengthen the heart's pumping action. So you want to make sure you check the heart rate before you give the digoxin and even after they're on the digoxin. To reduce the workload of the heart, to conserve energy, we want to put them in a semi-Fowler's position or in an infant seat. We want to give them a pacifier. We don't want these babies crying all the time because when they cry, they increase the need for oxygen, which they can't deliver, right? So give them a pacifier, do cluster care, which means that you're going to go in and do all of your things at one time so you don't keep bothering these patients, these babies, or you don't make them cry 10 times a day. Instead, you make them cry twice when you go in to do everything or as much as you can, which means you're going to organize your activities to help conserve their energy. Diversional activities to meet developmental needs need to be done as well, but they also need to be activities that are going to conserve their energy, so remember that. You want to avoid extreme temperatures with these type of patients, so you want to keep them in a perfect temperature room, not too cold, not too hot, because anything that goes hypo or hyperthermia increases the body's demand for oxygen. And you're going to give them diuretics, specifically Lasix, to help eliminate the excess fluids. You're going to provide adequate nutrition by giving them a low sodium formula to help minimize the fluid retention. Remember, fluid goes where the sodium is. You're going to discourage foods with high or added sodium, again, to minimize fluid retention. You're going to do a daily intake and output, daily or weekly weights to monitor their growth, because they have what? Failure to thrive, right? So we want to make sure they are growing. You're going to give them PO Gabbage feeds to meet the fluid and caloric needs. These patients' bodies are working round the clock constantly. They're going to need higher calories. And you're going to give them foods high in potassium because you want to prevent hypokalemia. Remember, they're going to be on DIG. And you want to give them foods that are very high in iron, because the iron is going to prevent the anemia, which in turn is going to allow for oxygen to be delivered better, and it's going to decrease the demand. You want to prevent infection by, of course, doing your standard nursing infection prevention precautions, your hand hygiene. You're going to limit the staff and visitors, especially anybody who might be feeling sick. And you want to monitor for early signs and symptoms of infection. You're going to meet the teaching needs of the patient and the family, which means you're going to explain any and all diagnostic procedures that the patient may be going to, so blood tests, x-rays, urine, EKG, ECG, echo, cardiocath. Make sure you involve the parents, let them know what's going on. It's already scary enough. You want to explain the condition, the treatment, the prognosis. You want to make sure they know what is expected and what's going to happen, or at least the plan that they have in place to help their baby out. You want to teach them about their dietary restrictions. Remember how it said we want to limit their sodium and we want to give them foods that are high in potassium. And you're going to teach them about the medications. Remember how we talked about DIG, and it has a very narrow therapeutic level, so we have to teach them about that. And you're going to have to really sit down and discuss how to realistically adjust to life with heart disease and the kind of activities that are going to have to be limited on this baby.